I'm Dr. Harold Burkhart. I'm a pediatric cardiothoracic surgeon. I'm an associate professor here at Mayo Clinic, and so I do congenital heart surgery on kids and babies as well as adults who have congenital heart defects, so they have heart defects that they're born with. Well, a tetralogy of Fallot is a constellation of congenital cardiac anomalies. So there's these four things that were described back in the late 1800s by Fallot, and the four things are: there's a ventricular septal defect, so there's a hole between the two pumping chambers of the heart, a VSD it's often called, and then there's narrowing in the artery that goes to the lungs. So the pulmonary artery, there's narrowing at the valve, and there's often narrowing below the valve. So that's the second thing, pulmonary stenosis or narrowing. The third thing is you have the aorta, the big vessel coming out of the heart, is overriding the ventricular septal defect, and I'll show you what that means when we look at the model. And the final thing is that you have a thickened right ventricle in response essentially to having the hole in the heart and having the narrowing to the lungs. So that all together makes up tetralogy of Fallot. So one of the problems with, we talked about a hole in the heart. Well, there's a hole right between this wall to here, so I'd be able to see into that other ventricle. So that's one of the problems. The other problems, that's a hole in the heart. Then there's a narrowing right here. This is showing blue blood, this blue arrow going to the lungs here. So this valve would be narrowed, and there'd be a lot of muscle clogging up this hole, making it hard. So some of these kids, you couldn't get a pencil lead through the hole, and it should be quite a bit bigger than that. So in response to this, the muscle here, this isn't, but the muscle here would get very thick and muscle bound, and that in turn makes there be more muscle here. So it's kind of as time goes by, it gets worse and worse and worse because more muscle forms, and then you get more blockage. So, and then the final thing is, which will be hard to show, is this aorta is overriding. If you can imagine that hole being right here is overriding, so that when the heart pushes blood, it's pushing it right up into the aortic valve as well as here, because that aortic valve is overriding that hole in the heart. And so that's just what the definition of tetralogy of Fallot is. Tetralogy is not rare, but I think it's about 5 out of every 10,000 live births. So 1 out of every 2,000. So it's not the most common congenital heart anomaly we take care of, but in the scheme of things, it's something that we see a lot of, and one of the reasons is not only because not just because there's a lot of babies born with it, but because babies born with it continue to live for a long time into adulthood, and we're seeing them for problems associated with that long-term effects of having tetralogy of Fallot surgery. Usually, babies with tetralogy of Fallot can present one of two ways. They can, you certainly with these days with getting ultrasounds in utero, often it's picked up, not all the time, but it's often picked up, and it can be picked up with a fetal echo. But if not and a baby is born, usually if the baby will present with cyanosis, so the baby will be blue, and that's not often on the first day. There's an artery, the patent ductus arteriosus in a baby, that closes over the first few days of life. So as it closes, there'll be less blood getting to the lungs, and the baby will turn bluer. So that can be a way the child presents. Another way the child can present is he can not have too big of a narrowing to his pulmonary artery, so he's getting enough blood to his lungs, enough to stay pink, and he may not develop symptoms till later on in life, whether it's 6 months or a year of age or so on. So in those kids, it's often picked up with a murmur. Symptoms that they have, if a child, things that people should be worried about: does their baby have a congenital heart, really any kind of congenital heart anomaly that causes them to have cyanosis, so low oxygen. And symptoms are blue lips or blue fingertips, and that would be a tip-off. Irritability or difficulty eating, or getting tired when they try to eat. just running out of energy, so maybe they only are able to take in a half an ounce when they should be taking in 2 or 3 ounces, just because they work at it so much and they get tired out. So, and then to some extent, upper respiratory infections, multiple infections can sometimes be a clue. I think the main thing is they have to be watching for signs of things worsening. So, like, is their child gaining weight and eating enough? Because if they're not, then we got to worry about, well, they're too blue and they're not doing well, so maybe we ought to be doing a full repair sooner than waiting the 4 to 6 months. Need to be going to a cardiologist and their pediatrician, and they check the oxygen saturation on their skin. And if it's getting too low, then we worry about that, and we worry about pushing the surgery sooner. In addition, there are these things called TET spells where they'll turn real blue if they have some sort of stress, and the child will do stuff like squat or lift the legs up to the chest, and that kind of forces the blood back to go through the lungs and get more oxygen. That still happens. Fortunately, it doesn't happen as often because we tend to fix them earlier, and we don't see it as much as before when you used to fix it much later in life. But those would be the things you'd watch for that would maybe push you to do it sooner than waiting the 4 to 6 months. We show a little graph, a tube graph, that goes from an artery coming off the aorta that has oxygenated blood, and the artery goes down to the lung artery. So that new blood going to the lungs makes up for the fact that there's a narrowed artery going to the lungs. So you add a little more blood. And that's what's called a palliation, or that's, you're getting them through that to hopefully do a complete repair. Nowadays we do a complete repair most all the time on children at the age of 4 months, but we will do it earlier if they're blue. Often kids are just little blue, and maybe their saturations are okay, and they're kind of well balanced, and you can wait till they're four months of age and then do it. If they're not, and they're severely cyanotic and they need to be done early on, then we will do a complete repair, but sometimes there's certain reasons to do a shunt. If they're very small or they're critically ill with other things, or they can't have open heart surgery, then we would do that shunt just to get them to a bigger size or an older age and over these other things to do the surgery. Now, the complete repair involves cardiopulmonary bypass, so it's open heart surgery, and we divide the breastbone and open the pericardium, the sac around the heart, and expose the heart. And then I'll put a tube in the heart that will take the blue blood to a machine and give it oxygen and bring it back to the aorta, the artery coming out of the heart, to give the child's brain and body oxygenated blood while we stop the heart. So that's the cardiopulmonary bypass. You're using the machine to bypass the child's heart and the lungs while we work on the heart. And then we'll arrest the heart. We'll use a preservative that keeps the heart cool and keeps it stopped, and then we'll restart it after the operation. But it's a similar thing that we would use if we were to want to use a heart for a transplant. We would stop it with this liquid that stops the heart. And then what we would do then is we would close the hole, that ventricular septal defect. We'd close it with a patch. We'd sew that in there. And then we would open up all this muscle, sometimes cut these muscle bands underneath the pulmonary valve. And then we would look at the pulmonary valve, and if it was big enough and the problem was really the narrowing was at the muscles, we would be done. If the valve, the ring of the valve going to the lungs was too small, we'd have to cut across it and sew a patch there. And that would relieve the obstruction to the lungs. So then it's actually a very good operation, because before they go in, you have these babies that are very blue, and then when they come out, they're pink and they have normal saturations and essentially a normal functioning heart, in that they have 2 pumping chambers, and the blue blood and the red blood are separated by walls that are intact. And so what we would do when we repair the heart is we would do it down through the atrium, so we wouldn't have to cut through the muscle of the heart and avoid hurting the ventricle permanently. And then, but if you can imagine, we'd be looking through this valve over here after the heart stopped, and I'd sew a patch in this hole right here, and then we'd come from above and look down this valve, and I'd cut through here and here where these 3 cuts should be, and make sure nothing's fused and that it's wide open, and then we would cut the muscle here down through the valve and up through here if we can, to try to save this valve, because we know long term it's better for the child if this valve is not leaking. Now, what I was talking about before was that if we do all that and it's still too narrow because the ring of the valve is narrow, then we have to cut across it and sew a patch, which would open it up. And again, children tolerate that, but we know long term there's a good chance they're going to need a valve put in here one day. But that just says we need to follow them up. Acute recovery in the hospital is typically about 5 to 7 days, and again, depending on their age. If you did the operation in a 1-month-old, it would be different than in a 4-month-old. But I think it's safe to say 5 to 7 days in the hospital, and then over the next few weeks they'd be getting stronger at home and be acting pretty normal. But I think that's an important point, because they do act pretty normal after they're repaired, because they have good saturations and they have 2 good functioning ventricles. So you do have to continue to follow up with a cardiologist, your pediatric cardiologist, and they will often want to do an echo or an ultrasound of the heart once a year to make sure things look good, because there's certain things long term that can develop, like we talked about. If you have to cut across that pulmonary valve, well, then that valve is going to leak, and that's tolerated very well in children, but we found that with time in young adults, sometimes even in kids, but in young adults and older adults, their right ventricle, it will make the right ventricle work too hard. It will dilate it out, and the heart will get tired. And so one day we may have to put a pulmonary valve in that position with another open heart surgery, which isn't, that surgery isn't quite as complicated as the first surgery, and it's not a very high risk operation either. If you're doing it at a center that does a lot of adult congenital heart surgery, we tend to do a lot of adult congenital heart surgery. So that's why I was saying earlier that it's a very common operation, putting pulmonary valves in patients who've had tetralogy repair as kids. But I think that's important, because you don't want to not be followed up and then show up 20 years from now in really bad right heart failure, thinking that, well, maybe we should have put the valve in 5 years ago to avoid this. Other things, if their heart gets big like that, they can have arrhythmias or funny rhythms. And again, that's just lends credence to the importance of following up with cardiology. The things that are different here, the biggest difference is that we're a congenital heart center. So whereas most people have the kids and the adults being done by different physicians at different institutions, we have a congenital heart center where we have babies with heart surgery being done by myself and my partner, as well as adults with congenital heart surgery being done, and we don't lose them to follow-up. They're followed by their cardiologist, and we have cardiologists who specialize in rhythm and intervention, and we have anesthesiologists that specialize in this, and we have access to these people all the time, and there's experts on the adult side as there are on the ped side, and there's a lot of crossover. So we think it's a good idea. We have a lot of smart people looking at their baby or themselves after their heart surgery to ensure that they have the best possible outcome. And we have the busiest adult congenital practice in the nation, if not the world, and we're prepared to deal with operations that a lot of people are a bit nervous about. Just in general, in closing, advice to parents is, if their child has tetralogy of flow and they need surgery or have undergone surgery in the past, or they themselves have it and have undergone surgery, it really is key to stay hooked up with a competent pediatric cardiologist, whether it's here at Mayo Clinic or in their hometown, because we are finding that there are issues long term with patients with tetralogy of flow that can be avoided if we stay in touch with the cardiology and you stay in touch with medicine, so that if there's surgeries, we can do it. If there's medical management, we can do it. But it's certainly better to be proactive in your health or your child's health rather than reacting to a bad situation.